Hey everybody, thank you for taking the time out of a Wednesday evening, and thank you to James for joining me tonight. We're going to talk a little bit about ASCO updates from GI ASCO about 2 weeks ago, particularly some new drugs for HER2 positive patients and a new strategy emerging for Claudin possibly. And then there are some people who submitted questions ahead of time. If you do have questions, you can write them in to the chat and we will try to get to them. As you know, if you've been to this a few times, we can never get to all of them, but we will do what we can. So I'm Sam Klempner. I'm a GI medical oncologist, and today joined by a good friend not too far away, James Cleary at Dana-Farber. I don't know, James, if you want to introduce yourself.
I just wanted to say how excited I am to be here. I'm James Cleary. I'm a GI medical oncologist at Dana-Farber. Like Sam, I also work in Boston, but really, I'm excited for two reasons. I always love coming to these W Streams town halls, but also getting to talk about gastric cancer with Sam is always an incredible pleasure. So this is going to be a lot of fun.
I will try to make it fun for everybody. So we like to start these with a couple short polls, and the intent of that is really to understand who's here and things that we can learn about the people that come to the town halls and make sure that we're tailoring these to be best serving the community. So the poll to start off is if you're on treatment, what phase of treatment are you on? Newly diagnosed, first line, meaning the very first chemo combination you're on, second line, meaning the second combination. We should probably add other somewhere on the line, but we'll give it another second because about half the people here have answered so far. All right, so this should show the results. You should be able to see, but about half of the people who responded are on first line treatment, a good number of people on surveillance, so not on active therapy, and then a couple people, it looks maybe just one person on second line. So you came to the right place because a lot of the discussion is going to center around first line treatment. And that is where a lot of the biggest advances, I think, are probably happening. So, James, I'm going to come to you to sort of give us an overview of um, the HER2 stories that are emerging. Sort of what is the, maybe start with a little background on HER2 and why this is important.
Yeah, so HER2 is a important biomarker in gastric and esophageal adenocarcinoma. And really, historically, it's one of the first targeted therapies we had in oncology. And it really came from breast cancer. So a lot of work was done with a drug called Herceptin, also called trastuzumab, in breast cancer. And trastuzumab is just an antibody that can bind to a protein called HER2 on the surface of cancer cells. And what was extraordinary was when they gave Herceptin to breast cancer patients, they saw it was very efficacious. And so really breast cancer really led the charge on trying to come up with therapies targeting HER2. And then probably about 10 years, 15 years ago now, copying breast cancer, we knew in gastroesophageal cancer that about 10% of patients have HER2 amplification of too many copies of HER2, just like breast cancer. And people started working on seeing if Herceptin works, if targeting HER2 works in gastroesophageal cancer. And it has. And so for the longest time, we were just giving chemotherapy along with Herceptin, and it was better than chemotherapy alone. But then a few years ago, a team led by Memorial Sloan Kettering, Yelena Jajigian, did work showing that adding immunotherapy to chemotherapy and HER2 targeted agents really seem to work even better. So it's really been an exciting time. And at GI ASCO out in San Francisco, we learned even more.
Yeah, I completely agree. So very important for everyone here to sort of know their HER2 status when you get diagnosed. It's really one of the critical pieces of information to help us decide on what's the best therapies for you. So I completely agree. We were sort of making slow advances in the HER2 space, and then we saw this perhaps clear advance in HER2 targeting. So if you don't mind just giving everybody here, James, a little bit of an overview of the Horizon trial and
Oh,
what you think about it.
yeah, and actually, this is going to be a great discussion, but I have to sort of say my thinking's evolved on this as I've heard more and more about it. Um, but what the Horizon trial did is they took a new HER2 antibody that's called biparatopic. But basically, instead of binding to one part of HER2, it binds to two. So it binds to two aspects of HER2. And you could think about that maybe as binding even stronger. And so this drug, this HER2 antibody that hits two different parts of HER2, is FDA approved already in biliary tract cancer, and it's called zanidatamab. And GI oncologists are getting experience with this, but we've been looking for ways we could use zanidatamab more broadly. And so in the Horizon trial, they looked at a couple things. They looked at the control arm was what we used to do, which is giving chemotherapy with Herceptin. And then it compared it to patients getting chemotherapy and zanidatamab alone, and also chemotherapy, zanidatamab, and an immune therapy drug called tislelizumab. And what they found is that the patients who got zanidatamab and chemotherapy stayed on therapy longer than the patients who just got chemotherapy and Herceptin, which made a big impact on me, just saying that it seems like if you get chemo zanidatamab versus chemo Herceptin, this new HER2 drug, that you can stay on it a little longer. And that made a big impression on me. But really, the main punchline was that when you gave all three drugs, the HER2 targeting drug, the chemo, and the immunotherapy, that really improved survival. And one of the reasons people are so excited about this is it improved median overall survival to 24 months. We've never really seen that in gastroesophageal cancer before. So it really was a big milestone. So I think there was a lot of reasons for enthusiasm.
Yeah, I completely agree. I think this is a better drug. I think we all expect this will be approved by the FDA in the coming months, and then will be more widely available to our gastric cancer and GE junction patients. I also thought the what we call the progression-free survival, which is basically from the time you start the therapy, how long does it control your cancer, is I think a simple way to think about it, was about a year. So that means like the average time people were getting this drug with control of their cancer was about a year, which is a significant improvement from, 6, 8 months, 8, 10 months that we get. So this is a big deal, I think, for the HER2 world. Tell us a little bit, obviously we balance this enthusiasm for the efficacy and we have to balance it against side effects. People are going to be on these drugs for a while. So sort of new drug comes with improved survival, improved tumor control, but also comes with some side effects. So maybe educate us a little bit on the side
Yeah,
effects.
yeah, Sam's completely correct. So I think, like Sam just said, that this new HER2 drug, zanidatamab, I think it's better than Herceptin. I think this trial is starting to show us this. When they compared, when patients got chemo, Herceptin, chemo, and this new drug, zanidatamab, the people who got chemo, zanidatamab had a better progression-free survival, stayed on the drugs longer. So I think it is a better drug. And that's one of the things this trial taught us. But with a better drug can come more side effects. And one of the things we saw was diarrhea. And I think we're just going to have, as GI oncologists, we're going to have to get more experience at controlling this diarrhea. One thing is that the way the trial was designed is patients got a form of 5-FU in pill form, Xeloda, which we also know can cause diarrhea. So I wonder if when it kind of gets into the real world, people will use infusional 5-FU and maybe that diarrhea will become a little more manageable. But in addition to diarrhea, people can also get infusion reactions and sometimes rash from this as well.
Yeah, I think, it's basically everybody who starts on this drug is going to start taking Imodium at the same time they start their treatment to try to prevent or minimize the diarrhea. And it does seem that that can help, but doesn't make it guaranteed you won't get it. Uh, I think,
Yeah,
yeah, go
I
ahead.
was just going to ask. So, in terms of thinking about this trial, when I first heard about it, I was having trouble because we already have a way. We already have an immune therapy combination. We have Herceptin, Pembro, and Folfos, which just wasn't comparative. So when I first heard about it, I said, you can't compare one trial to the other. I wasn't as enthusiastic about it. But when I meant my thinking has evolved, is when I started really thinking that the zanidatamab chemo arm was better than the trastuzumab chemo arm. And that's when I really started thinking if I was a patient, even though you're not comparing the one regimen to the other, I think I'd want the chemo zanidatamab tislelizumab arm. But I was curious to see what you thought because I've been my thinking's been evolving on this.
Yeah, me too. I think for everybody listening, there was some debate about, how much does the immunotherapy add on top of the chemo and the new drug. And when I look at the responders, so about 70% of people respond to this combination of therapy. So a very, very good chance your tumor will shrink. And then when you look at the people who respond and you ask, how long is their response, what we call duration of response, the Tisli arm is very long. I mean, it's like 20 months. And so that I think suggests that the immunotherapy is adding or contributing, and that the sort of the triplet arm curve kind of flattens out a little bit higher. So these to me, I think I agree with you. If I was a newly diagnosed patient, this would be a combo that I would seriously consider and discuss. There is a question in the chat, James, to you, which is really about, maybe just remind us like where in the disease course this was tested. The question is it only being used as first line treatment?
That's such a good question, and that's correct. So this is really for patients who either were just diagnosed or just developed metastatic disease. So it's really for patients who developed cancer outside of their esophagus and their stomach and are getting treated for that metastatic disease for the first time.
And then I don't know what you're thinking, but certainly there's always these windows of periods of time where we have the data and we want to get the drugs for patients when we see them, but we don't technically have it on NCCN or
Yeah.
FDA approvals. So I think one expectation setting, new patients, we may try to get this, but we may or may not be able to. So have you had any experience trying to navigate this yet? I have only one experience.
I haven't had that experience yet. I will say I had the experience in biliary tract cancer. I think it'll be a little easier since it's FDA, since zanidatamab's FDA approved in biliary tract cancer and tislelizumab's FDA approved in lung cancer. I think it's going to be easier to get than when the drugs hasn't been FDA approved before. Hopefully.
Yeah. Yeah, I'm one for one so far. But um we'll see what happens. I think that we hear the patient community loud and clear that there's a real push to get this on. But the FDA still takes their time to do their reviews and things. We don't have a whole lot of control over that.
Yeah, actually, just to sort of amplify that, it's going to be insurance dependent. I think it gives me a lot of hope that you got one person this drug, but I can imagine some more restrictive insurances are going to say no for
Yeah.
now.
Yeah, for now. Agree. And it's always a tough spot for this Windows. I mean, you had the experience with no nivolumab after chemotherapy and radiation and surgery.
Yeah.
Uh, we know. There's a question to you in the chat specifically about other HER2 developments, particularly HER2 low, and maybe just comment about targeting of HER2 low disease in stomach and esophagus cancers versus obviously this gets a lot of press in breast cancer.
Yeah. Well, first, just to sort of set the stage for everyone, we've been talking about first line targeted therapy with HER2. But then the question is, once this regimen stops working, what are you going to do? And I think for many patients, you can continue targeting HER2, which is great. And very important, after you stop first-line therapy, you want to make sure that your tumor still expresses HER2, because one of the ways cancers can become resistant to HER2 markers is you were HER2 amplified, now you're no longer. So it's important to do a molecular test just to make sure your cancer still has HER2. But if after progressing on first-line HER2 therapy, your cancer still expresses HER2, right now the standard of care is to do a drug called trastuzumab deruxtecan, also called Enhertu, which is a HER2 antibody that has a chemotherapy attached to it, which has been remarkably effective even in patients who progressed on HER2 therapy. So that's also called an ADC, an antibody drug conjugate. And so that's been a wonderful advance. But to get to the question, as Sam said, in breast cancer, what's really still blows my mind is that you can, when patients only express a tiny bit of HER2 low, that trastuzumab deruxtecan can be effective. To date in gastroesophageal cancer, that has not been the case, but people are still looking to see if there's strategies we could use to attack patients who are HER2 low.
Yeah, I agree. We don't have drugs really for that population that I think we feel good about. Sort of an extension of the question in the chat as well. You mentioned that the importance of after trastuzumab has stopped working or after zanidatamab stopped working, the importance of biopsy. So sort of, can you go from positive to negative, or could you go from negative to positive?
Such a good question. So you definitely can go from positive to negative, and that's why it's so important to check. On the reverse, I have never seen anyone go from negative to positive, unfortunately. Now, there are some patients where there's HER2, and this kind of gets into weeds a little bit, where there's HER2 heterogeneity, but for those patients where there's some heterogeneity, I'm oftentimes not that excited about HER2 therapy in general anyway.
I agree. I think most patients, if you see your own results, it will say like 3+. That's generally the people who do the best with most of our HER2 therapies. And then there's the 2+ and FISH positive, which are technically positive, but maybe the HER2 is not quite as important to the cancer as the 3+ people. Um,
Sam,
yeah, go ahead.
I was just going to say there's two ways of doing molecular testing to see if you still have HER2 expression. One is for the people here, cell-free DNA, where you can do a blood test. And the advantage of the blood test is it comes back really fast. And the other one is a biopsy. I have to say, just because biopsies can take so long, I've been tempted to do cell-free DNA on my patients just because the results come back so quickly. But I was curious to see what's your general practice?
Yeah, I like it as a first pass test also. Sometimes I've had a situation where when people have had responses and they have a low amount of disease, that there's like too little amount of cell-free DNA to do much with.
Great point.
But totally agree with you. It's, within 7 days you have a result, and it takes us 7 days to schedule a biopsy.
That's yeah.
Yeah, we're definitely not any faster on this side of Boston than the other side of Boston. Um, the I want to get to your perspective on any other cool stuff you saw or heard at GI ASCO, just sort of generally in the space for people here.
Well, I think one thing, so Sam and Debbie Stream posted a wonderful seminar that happened at Mass General Hospital in the fall. And I actually think there's videos of it if anyone in the audience wants to watch it. And one of the themes of your whole day was biomarkers and how HER2 is one biomarker that helps us pick treatments for gastric cancer, but there's other biomarkers, and one of them is Claudin 18.2. And so recently there was a FDA approval of another antibody called zolbetuximab that's effective in patients with Claudin 18.2 positive gastroesophageal cancer. But the challenge is What do you do? How do you rank the different therapies? And at your seminar, Elena made a priority list. I happened to make a priority list. We had the same priority list where we
Yeah.
basically put that we would give immunotherapy, things like pembrolizumab and nivolumab, with chemotherapy over zolbetuximab if they've had both Claudin 18.2 positivity and PD-L1 positivity. But where Claudin 18.2 is nice, if you're PD-L1 negative, you don't have another biomarker, that's a way that you can combine an antibody like zolbetuximab with FOLFOX. But what I was excited about at GI ASCO is I wish we didn't have to choose. I wish we could just give the immune therapy and the anti-Claudin 18.2 antibody. And there was a nice phase 2 trial suggesting that maybe that would be an effective strategy, that one day we'll be able to give chemotherapy. Will be if the patient's PD-L1 positive, we can give the immunotherapy, nivolumab, and we can give zolbetuximab. So basically, two biomarker-driven therapies along with the chemotherapy, which is very exciting.
Yeah, totally agree. I know a few people on this, I see a few names on this call who may have been treated in such a way. Um, yeah, I completely agree. It would really simplify things for patients. And if the phase 2 data holds up in a phase 3 setting, which is being tested now, then it would be great. I mean, the progression-free survival in that trial was about a year also. So it's not so dissimilar from the Horizon, but to people listening, the quality or the weight we put on the data from a phase 3 trial is definitely higher than a phase 2 study, because the study that James was mentioning is not randomized. So everybody got the same treatment and there's no control arm. That is what the phase 3 trial, which is called Lucerna, is testing the triplet combination against chemotherapy plus immune therapy. I want to get to the people that submitted the questions ahead of time, and then I saw a question from Esther in the chat, which I think we'll have time to get to. But as usual, a lot of great questions submitted ahead of time, and we've been talking about lines of therapy and multiple lines of therapy. And Michael, I don't know if you're on, but if you want to ask your question or if you want me to read it, please speak up if you want to just ask it. You might be on mute if you're talking.
It might be that the audience are totally muted.
Oh, perfect. Well, I
Can
will.
you hear? Can you hear me?
Oh, great.
Yes,
Yes.
yes.
Okay. So hello from Canada. Um, my question for you is um, has to do with the exhaustion of lines of treatment and what is considered exhausted to the point where you would move on to a second line. So basically, I in April I completed 12 rounds of Folfox plus Herceptin plus Keytruda. And all my scans were NED after having significant disease in the peritoneum upon initial diagnosis. And then I went and had a HIPEC at Mayo with Dr. Groats, and he gave me a PCI score of 0. And then over the summer, I had a couple more treatments of the Herceptin and Keytruda, maybe 2. But then in August, I had a recurrence of the original tumor, and then I got radiation. So the next step, I'm wondering, would you consider the first line of therapy to be exhausted, given that it reoccurred between the time period of April to August, or would that be something worth re-challenging?
Can I ask you a question before I go to James for this one? So,
Of
um,
course.
so you said the tumor came back in the original area, but
Yes.
how do you know that it went away in that area completely before? Like at the time of your HIPEC, did they also do an endoscopy and prove that the stomach tumor was completely gone?
Yeah. So the the surgeon from Mayo did the gastroscopy, and he couldn't find anything.
Okay, perfect. So
And then it was discovered again in August.
because you had a symptom or just because you had a scan?
Because my doctor here ordered, she wanted to do an I can't remember what the tube is called, but it's kind of an ultrasound of your other organs.
Hmm.
And the surgeon couldn't get it through, and he's like, "Oh, the little tumor has regrown." Endoscopic ultrasound, is that right?
Yes,
Yes,
EUS or endoscopic ultrasound would be.
endoscopic ultrasound. Yeah, thank you. Yeah, so then that's how it was discovered, just kind of by chance in August.
So James, it sounds like, this, well, maybe talk a little more broadly about sort of patterns of progression and oligo progression versus more systemic progression and sort of how you think through this. I know HER2 is almost a unique paradigm in this setting.
Yeah, this is such a interesting clinical case, and trying to figure out the right thing to do. Before I even say what I would do, I have to say, if you got a bunch of oncologists in a room in a case like this, you're going to get a lot of different answers, because there's many equally reasonable ways to go. But in general, when I think about what means progression on a therapy, and I think this comes to the heart of this question, is in its truest form is when you're treating someone with chemotherapy, and despite the fact that the person got chemotherapy last week, you get a scan and the cancer got bigger. So the patient's actively getting chemotherapy and the cancer grows. Um, what always is a challenge is when a patient gets a treatment holiday, and that's basically what happened here. You went to surgery in April and didn't receive any more HER2 or any drugs, any anti-cancer drugs, what we call systemic therapy, from April to August, and the cancer came back. And then the question was, well, should we give up on these drugs, or was it just the drugs were working? He just hasn't gotten it in that long. And it's always a judgment call there. I oftentimes will keep the number of 3 months in my head. Just if someone hasn't gotten therapy for 3 months, maybe you should give it another try. Whereas if you progress 2 months later, it probably would have happened anyway. You probably can tell that's not very scientific, but it's the number I keep in my head as a rule of thumb. So I think this does get by 3 months. And really, as you're asking your question, I was thinking there's two equally reasonable ways to go. And that's actually what I want you to hear. I think there's two equally reasonable ways to go. I think trying Enhertu here, trastuzumab deruxtecan, the antibody drug conjugate, would be very reasonable. But trastuzumab deruxtecan has a lot more side effects. It has chemo-like side effects. It's harder. So I think if I was a patient, I'd want to go back to I think I'd go back to chemo, and depending, I'd do some sort of chemo, whether it's 5-FU oxaliplatin or 5-FU alone, and I would do 5-FU, Pembro, and Herceptin again, just because I feel like the side effect profile would be better, especially if you can get rid of the chemo, you do well.
The only thing that changed was that my PDL score went from 20 to 1.
Yeah, I would tend to, regardless of that, there's a lot of heterogeneity in PDL1 scoring, but I would tend to agree with James. We try to milk as much as we can out of each line of therapy, and technically you're still on first line therapy, now, well over a year, which is great. I would agree. I would try especially when patients have a lower burden of disease. If you had metastases all over, I think we would probably lean towards the TDXD, but it sounds like you still have a pretty low burden of disease. I agree. I would try to add back chemo to see if you can reinduce a response and then try to get more out of this. And then as James said, if ultimately that doesn't work, then you've got a very good backup option.
Thank you very much.
Um, I saw Kara wrote in a question I want to give. I see your name if you want to unmute and ask, or I can read it.
Sorry, can you hear me?
Yes.
Yes.
Okay, hi. Um, Sorry, we're driving. Okay, so my husband completed 8 rounds total of chemo, and well, after 5, he had an esophagectomy. Sam, I know I've talked to you about this before. And then he did 3 rounds after the esophagectomy. We finished that in November. And he's had 3 circulating tumor DNA tests. They've all been negative. He just had a PET scan in December and he was NED. So right now, the tumor board where we're at, we have Kaiser. They're going to review his case, and we're kind of waiting to find out. Originally, our oncologist said immunotherapy, the Opdivo, in since for a full year from the original time that he started. So his first cycle was April 1st of 2025. So he's still been doing immunotherapy every 2 weeks. And now we're kind of waiting for the tumor board to kind of tell us how long or if that's still the plan. I guess the more that I've been kind of reading, it scares us. Like, do we stop? Do we ask to continue? What would the reasoning be to not continue?
So I know you came to Boston, and I think you
Yes,
probably both James and I at the at the symposium,
yes,
and that was great. Just remind us. So I know technically he had stage 4 in the beginning
yes.
because of lymph node, and then had a surgery and is being followed. So, James was involved in the trial and one of the people that led the trial that originally defined immune therapy like after surgery and radiation. Um,
Okay.
so I don't know, James. So this case sort of straddles the paradigm as it's evolved. But how do
So,
you think?
yeah, he was stage 4 because he had a lymph node by his kidneys. And then on the PET scan after 5 rounds, that lymph node was gone. But based off where it was, they said they couldn't remove it. So then on this last PET scan in December, it still isn't showing up, now that he's NED. So they even referred us to a radiation oncologist. And then he said, well, there's nothing for me to do. So we're kind of like, I mean, and our oncologist tells us we're in a gray area. So we're kind of just waiting.
Maybe James talk a little bit about the role of Signatera or ctDNA as you see it. Sounds like 3 negative results.
Hmm.
And then 2, sort of duration of immunotherapy in standard perioperative care, and then, sort of maybe any comments on this case specifically.
This is an extraordinary case, and I'm really glad your husband's doing so well.
Thank you.
And so for the audience, earlier, Sam and I were talking about cell-free DNA, a way of looking. So cell-free DNA is basically cancer cells can shed DNA into the blood, and you can detect that cancer-specific DNA just from a simple blood test, which is amazing. And you can find certain mutations and things like HER2 amplification. That's one way to use cell-free DNA. Signatera is a different way where basically instead of asking what mutations are, they're just saying, is there any cancer DNA there at all? With the idea being that if a patient's cured of their cancer, they won't have any cancer-specific cell-free DNA, whereas if there is cancer-specific cell-free DNA, you probably know there's some cancer cells there. I have to say what I just said is far from foolproof, that our technology isn't that great. And I've taken care of patients where the Signatera cell-free DNA was negative, but we knew they had cancer cells. So there are many false negatives. So please know that this test is still foolproof. And that's why really the first thing I would say is really in terms of using it in routine care for gastric and esophageal cancer, I don't use it routinely. However, in special cases, and I think this is one nice use of it, I do use it to try to get some more information. And so seeing that the Signatera cell-free DNA was negative, it's great. It's encouraging. Again, it's not foolproof. And then the question is, how long should we do immunotherapy after someone's had their cancer removed? And to be very honest, we don't know. This comes up in the metastatic setting too. Like how long should we do immunotherapy? We take our best guess at it, but the trials are a year in this setting. And that's why I agree with your oncologist. I would do the immunotherapy for a year. I think that's where we have the best evidence. So yeah, I would just keep going with the nivolumab for 1 year.
Okay, perfect. Thank you.
All I would tend to agree. I think there's obviously some reservations about stopping a therapy. Everybody gets a little bit nervous, but there's also side effects that can happen in year number two from immune therapy. Just because you didn't have any side effects for the first year doesn't mean that you can't have a bad side effect later on. So we're always trying to balance that.
Okay. And would you guys do surveillance every 3 months?
Personally, in someone who is technically stage four, I would at least for another year or so, 3 or 4
Okay.
months, somewhere in that range.
Okay.
But
So
Totally agree.
we were gonna do the Signatera every 2 months and then the PET or CT every 3 months.
yeah,
Does
a lot
that?
of people do
Okay.
that kind of
Okay.
staggering. Yeah,
Perfect. Thank you guys.
very reasonable. Um, all right. I see one more question, but I see this question in the chat is timely from Rebecca. I don't know if you want to ask it yourself or you want me to read it. Well, I'll read it while you're seeing if you're coming off mute. But James, we were just talking about Claudin in the front line with chemo and immunotherapy, but it's still a target. Why not go after it in the second line or later? Are there any active things there, or yeah, maybe just the general second line Claudin space and beyond?
Tremendous question. And I think right now the answer is sadly for standard of care. We only could use Claudin in first line. I've actually tried to get it. I've had one success getting it late line because the patient just never got a shot at it. But in general, you just can't get it after first line. Um, and there's, to be fair, there's not a lot of evidence with silvetuximab that works beyond first line. However, I really hope that we'll have a seminar like this in 2 years and the answer is going to be different. And there's a lot of clinical trials in this space. There's a lot of clinical trials testing Claudin 18 antibodies, antibody drug conjugates. There's even one of CAR T cells. So there's a lot of trials in this space. So we're really hoping that in the future we will have anti-Claudin directed therapy in lines beyond first line.
Yeah, totally agree. I think I wouldn't be surprised if some of the ADCs are better than standard chemo, and especially in the like third line kind of setting.
Oh, yeah.
So I'm optimistic, but I agree we got to wait for the data. Um, this is a very good question and general question that was submitted ahead of this webinar, which is about something that probably oncologists and fellows struggle with also, but it's about how do you find information and what's relevant. So the person writes in, I'm supporting a loved one with stomach cancer. ASCO always brings so much information. How can caregivers understand what's truly relevant and what we should bring back to our medical team? And maybe that's even an opportunity for ASCO to have some new sessions. But if you were advising this person to like how to navigate ASCO data, like what would you say?
I actually think they're in the right place. I've been very impressed by organizations like Debbie's Dream having a patient information session like this. So I think things like this are great. Sometimes NCCN will have patient education series. If I had a loved one who had cancer, I would also be on social media. I agree social media is tough, but you'll start to see who the experts are in the field. So for example, Sam's one of them. Yelena, I always say her name wrong, but she's at Memorial Sloan Kettering. She's wonderful. Trying to find like the experts, Sam and Yelena, I think if you follow them, you'll sort of see really what the big developments are in gastric cancer.
Yeah, I agree. I think Chat GPT to say, what's new is maybe not the most reliable yet, but maybe we'll get there. I agree. I think all advocacy groups serve a very important role in sort of educating and disseminating information, and things like this are great. Unfortunately, getting awareness out there is still a limitation, even around us in Boston, you can go 40 miles from Boston and people will never want to come to Boston. And it's hard to get, information and make sure everybody's getting the best, even standard treatments. it's not just a problem for stomach cancer. I mean, it's just a problem for oncology. And like we can't do clinical trials in rural areas very well. It's just it's a problem for healthcare delivery, really. But yeah, it's a great question, and I totally agree with James. Sort of another high level question, which is, a lot of people here are extremely well informed about their own disease and have educated themselves and each other. But just to back up, tell us a little bit about staging, and first of all, why do we care about staging? And um, does the stage ever change? Like if your cancer goes away on a scan, are you a stage zero? Talk a little bit about staging and why it's important and sort of does it ever change?
Yeah, staging is just incredibly important in really trying to figure out what's the best therapy for your cancer. So I think whenever I'm seeing a patient, the question I'm asking myself is, what treatments can I give this patient to get them the best possible outcome? And so one of the things I like to know about are biomarkers because that can help me, but stage is equally important. Like you just want to know what because our clinical trials, we've been talking a lot about clinical trials. Our clinical trials are for specific stages. So when we were talking about clinical trials at the beginning, those were all for patients with metastatic stage 4 tumors. But there also are clinical trials for patients with things like stage 2 and stage 3 gastric cancer. So, and one of the big trials was called Matterhorn that happened for stage 2 and stage 3 gastric cancer, and that really changed the way we treat those cancers. So, I guess the way I would answer that is staging influences how you're going to treat a cancer. It also influences the goal. So when I take care of a patient with stage 1 to 3 gastric and esophageal cancer, we're trying to cure those patients. Whereas stage 4, we can't cure them, but we could give them treatments to allow them to live as long as possible. So that's the way I think about staging. And the other way to sort of think about it is in stage 1 to 3, the higher the stage, the higher the chance it is of going to metastatic disease.
Sorry, completely agree. Um, and what about like we heard a couple cases, really good outcomes, people who had stage 4 disease and then their scan became negative, no evidence of disease. Does that mean that their stage has changed?
First of all, that's wonderful. And we love to see that. I wouldn't say their stage has changed, but I'm certainly a whole lot more optimistic about their cancer.
Yeah, I agree. We have people who walking around 5 years after stage 4 disease, and unfortunately, they're still stage 4, even if they haven't had a cancer treatment in 2 years and their scans don't show anything. It's you can't really escape the stage, which, it gets a bad rap, but it's really just a broad tool for us. I saw I saw Brenda wrote in. So Brenda, we actually do have time, I think, if you want to ask your question.
Thank you. Yeah, so I am a cancer caregiver. My husband has stage 4 signet ring cell carcinoma. He did 24 rounds of Folfox, 4 rounds of irinotecan that did not seem to work, and has done his first cycle of RAM PATs now, which I feel like there's a slight improvement in him in the last week or so. He had like the completed cycle done on Monday. So in the last couple days, he seems a little bit better. There has been talk that after this, there may still be an option to try Folfox again with the Zolby. Listening to today's information, it seems like that's not typically something that's done or that's been seen to work. I guess my question is like, are they just kind of like giving me this just to give me a little bit of hope, or what, where have you seen that before? tons of things crossing my mind because, and his patterns seem to be throwing doctors off as well because the original tumor did shrink quite a bit, but his cancer metastasized pretty much just to the right side of his body in all of the muscle tissue. So from his neck down to his calf. So I don't know if that has to do with why they may think that that's an option. Kind of perplexed.
And
So,
did they biopsy one of those muscle areas?
yes.
And
So,
and sorry, the biomarkers, if you don't mind, if you know them.
yeah, he's HER2 negative, Claudin 18.2 positive with like I think it was 3.
Mm-hmm.
The other one, what's the other one? PDL1.
Yes.
That one's 0.
Okay. And so FOLFOX, then irinotecan-based chemo, and then Taxol ramucirumab.
Yes, correct.
So James, maybe just talk about, this situation. Where do you go after third line therapy? How do you think through your options? Sort of general comments.
Great question. And first of all, it sounds like your husband has just incredible courage going through all those treatments. It's incredibly impressive. Those are tough treatments. And I'm glad he's on the Taxol ramucirumab. And I think when we're in this situation, the challenge is, especially if he's still in good shape, you want to still continue to offer him treatments that you think could help him. But those options are limited. What I like to do in these situations is to try to get a patient on a clinical trial. Now, I don't know where in the country you live, and one of the sad things about our clinical trial system is I'm spoiled. I'm here in Boston. If I have a patient like this, to be honest, I'm just going to email Sam and send him across the street to Boston because they have wonderful clinical trials over there. But in other parts of the country, there are not a lot of clinical trials. And so what do you do? So if clinical trials not an option, after this, I'd have to look, as I said, I have tried zolbetuximab in a patient like your husband, along with chemotherapy, and I was able to get insurance approval for it. So depending on the circumstances, I might give it a shot. But the other thing you can think about is a drug called Lonsurf.
Yeah, I agree.
What's the name of that? I'm sorry.
Yeah, go ahead.
It's a drug called Lonsurf, LONSURF.
Yeah, there are some Claudin drugs in clinical trials for later line therapies. I think when we hear about a target and we know that a patient has a target, we are tempted to go after it. So I do not think it would be unreasonable to try something including zolbetuximab, like you mentioned, going all the way back to FOLFOX and zolbetuximab, but in total transparency and fairness, we have really zero idea if that's better than just FOLFOX. We just don't know. I saw a very nuanced question from Allie. Allie, if you want to ask your question or you want me to read it about pathologic and clinical staging. So you're maybe poking a hole in our arguments.
Oh, I just had a question. Is there any confusion with any patients that you've encountered where they're diagnosed with a clinical stage? Like, for example, in my case, Ron was diagnosed stage 1B. He didn't have any response, so he was upstaged to pathologic at post-surgery stage 3B. But have you seen that often on the reverse, where a patient might have lymph node involvement and they can be stage 3 or even, God forbid, stage 4? And then have a great response to chemo post-surgery and be able to maintain like long-term survival? Is there is there confusion with the patient, maybe a lack of understanding or education with that, between clinical and pathological staging?
Yeah, so maybe James, just start there. The difference between clinical and pathologic staging.
Yeah, it's a great question. So first of all, when we meet a patient, when you do surgery, you take the whole tumor out the pathologist can look at, and they can tell you exactly what the stage is. They can tell you how far the cancer penetrates through the gastric wall, how many lymph nodes there are. That's the gold standard. So pathological staging, almost by definition, is always correct. However, when you meet a patient, you have to take your best guess at what the person's stage is. And so to do that, we do things like CT scans, and we'll do endoscopic ultrasounds just to get a sense of what we think the person's stage is. So that's clinical staging. So clinical staging is really what you can say when a patient hasn't gone to surgery yet, but we're using things like scans and ultrasounds to try to take our best guess at what the person's stage is. But then pathological stage is when you take the tumor out and you know exactly what it is. Here's the thing. In the modern era, we commonly give a lot of treatment like chemotherapy before the person goes to surgery. So while the pathological stage before they got surgery, before they got chemotherapy might be one thing, once they get chemotherapy, hopefully the pathological stage gets lower. So that's also where some of the confusion comes in.
Keep muting myself. Totally agree. I think as sort of evidence for the imperfection or imprecision of our staging methods, sometimes we'll tell someone that the converse, that their CT scans show no lymph nodes, and then the surgeon will take it out and they'll find that under the microscope they can find tumor cells in one lymph node. And so then yes, technically your stage could move from a 2 to a 3 on the pathology. So that is a nuanced scenario where I guess technically the stage can change. And that's if we could see individual cells with a CT scan or a PET scan or an MRI or anything, then we could probably we could make better guesses in the beginning, like James said, but unfortunately we're limited by our technology. So that I agree that there is confusion there. It can definitely be a confusing scenario. There is one more question that was submitted. Oh no, I got to that. So actually, we do have a few minutes. We got like 5 minutes for sort of open forum questions. You can also just raise your hand or speak up if there's anything that you want to talk about, or I can just make some stuff up or tell some jokes.
I had a question. My mom has stage 4 signet ring. She's 80 years old. She's undergone 5 cycles of Folfox and Nivo. Her only biomarker is PDL1, which is 5. Unfortunately, she has a lot of chemotoxicity, so she's unable to walk. She needs support, etc. So typically, when this happens, do you kind of shift to just immuno and 5FU, or in older patients, what is the best thing to do?
Yeah, James, go ahead.
It's a great question. I think this is part of the art of oncology. So when you're taking care of a patient, you want to give them the most effective therapy, but you also have to pick a therapy they can tolerate. And oftentimes you need to recalibrate as you go. This situation you're bringing up happens all the time. And so the way I approach it is if the patient's not tolerating it, what sort of modifications can I make to the treatment to make it tolerable? And I think in this case, if your mom can't walk, I think one of the drugs, oxaliplatin, is notorious for that, and I would stop the oxaliplatin. And then I think the judgment call is going to be, my preference would be to keep going with the 5FU if she can tolerate it along with the nivolumab. But if the 5FU is too much for her, I would stop that too and just do nivolumab by itself. It really just depends, and you really have to work with your oncologist to try to fine tune this.
Yeah, I agree. Most people we even have some evidence in older or more frail patients that even starting right from the get-go on more reduced doses is probably okay.
Right. Thank you. They did reduce her dose to about 20%, but she just got wiped out after the 5th cycle of Folfox. So she's taking a little break. She's not had chemo for 4 weeks now. And be a meeting up with her oncologist tomorrow. But just wanted to understand what oncologists do generally. And thank you so much.
I think we are
interesting to know. Yeah.
We also use a little like a 2-week extra treatment hold sometimes as a diagnosis tool, because if your symptoms get better, off chemo, then usually it was a chemotherapy side effect. If the symptoms don't get better after you've been off chemo for a while, we have to ask ourselves, are we missing something else? And that's when we may explore other things like immune therapy can sometimes cause hormonal imbalances, thyroid or adrenal gland, and sometimes that can be profoundly fatiguing without being, picked up on routine blood work, for example. So I totally agree with James, but if it's not getting better, your oncologist would probably start looking for other causes.
Got you. Thank you. It is getting better. She's slowly and steadily gaining her strength back.
Yeah, that's encouraging.
Thank you. Thank you so much.
James, last question from Michael in the chat about what does oligometastatic really mean? And how do you use it as a factor in thinking about treatment?
It's a great question. And so typically when we have a patient with metastatic disease, stage 4 disease, we treat them exclusively with what we call systemic therapy, which is drugs, which whether it's chemo, targeted therapy, immunotherapy, but we really try to give systemic therapy so that the treatment goes into your blood and it goes everywhere. And that's really the idea for metastatic disease. Occasionally you'll see these exceptions where a patient just has one spot of cancer, say in their lung, and you've been treating them and say 6 months goes by and it's just one spot. In that case where it's really just one spot, yeah, I'm often tempted to be a little more aggressive than just giving cancer drugs. I want to try some intervention, whether that's surgery or radiation, but really we're looking for those oligometastatic patients where doing something beyond just giving cancer drugs like radiation or surgery could help.
Yeah, completely agree. I think we're very careful in selecting those people because we usually want to make sure at least our usual approach is at least 3 months, usually more like 6 months of sort of control with the systemic therapy. And then if you really have good control over everything except there's one stubborn area or one persistent area, then I agree, we do exactly the same thing. Think about surgery, think about radiation, etc. Well, look, it's 8:58. I want to be respectful of everybody's time. We probably have time for one quick question if somebody's got a quick question. Otherwise, we can give everybody back the rest of their evening.
Guys, thank you so much. This has been very helpful. I would ask in this case, piggybacking off of this last question, at that point, if there's only one area, do you do HIPEC or recommend HIPEC? At what point does HIPEC come into the picture?
Oh man, that's a whole hour session about.
Oh, is it? Okay.
But I don't know, James, you want to give like a 2-minute answer to that question?
Yeah, so that's such a great question because in my answer about oligometastatic, I have to say I purposely picked the lung because patients with lung-only metastatic disease tend to do really well. Other places were isolated, I might consider the liver, but lung is really the place where they can do particularly well. The challenge with HIPEC is that now we're talking about cancer in the lining of the abdomen called peritoneal carcinomatosis. And here we have a technological challenge that our CT scans just don't visualize the lining of the abdomen well. So while a CT scan might just show one spot, I have to say, whenever I see peritoneal carcinomatosis, I'm always suspicious that if there's enough that I can see one, there's probably a lot more. So I usually don't think of oligometastatic disease as peritoneal carcinomatosis, but I'm really curious to see what Sam's going to say.
Keep muting myself. Generally, I agree. I think, very, very selective. I generally, for patients where we're even contemplating peritoneal therapies, I do feel pretty strongly that it should be done on a clinical trial because we just don't really know the best way to do it yet. I don't think anyone in Boston has a clinical trial. I know that we don't at Mass General. So I've referred a few patients to Dr. Groats, Michael had mentioned. I've referred a few people to Dr. Sentil out at UC Irvine and Dr. Wu. Some of these people who have clinical trials trying to test this. I think we all know it's a huge problem for stomach cancer and GE junction cancer, and we really do need to try to solve the peritoneum. But to date, we don't know what the right strategy, if it's high PEC, if it's giving chemo into the abdomen, just like we give it into the vein kind of every 2 weeks, or if it's other ways to do it. PIPAC gets a lot of attention, but to be honest, we just don't really know the best way.
Okay. We're actually in the Richmond, Virginia area and seeing a surgeon out at VCU, Virginia Commonwealth University. They're kind of recommending it after 12 rounds of FOLFOX. We'll see.
Yeah,
Haven't made up our decision, yeah. But they want to do a scope first. I should preface it by they want to go look around again because last studies were all negative for disease following his surgery.
Yeah, I agree. Doing a laparoscopy to get information about the amount of disease in the lining is very reasonable, um, and might help you think, you know, that the chance of success or helping someone is a little better if there's a very small amount versus if there's a bunch of little grains of sand.
Right.
That may be a bigger problem. So yeah, I think the group at Yale is also very invested in peritoneal therapies. It's probably good to get a few opinions in that space if possible, just because
Great. Okay.
some people have very different feelings on peritoneal therapies in general.
Right. Great. Appreciate it. Thank you so much.
Awesome. Well, it's 9 o'clock. Thanks everybody for attending. I did actually, for people who are here, if we can do one last poll, because I forgot to ask this question, but if we could launch the poll about what is the most challenging about navigating your care right now, just so we can make sure we're hitting the key things for these webinars. Looking like a relatively even breakdown of everything. So hopefully this will pop up now and you can see it. But understanding medical information, accessing trials and treatment, managing symptoms, and emotional well-being are the top 4 out of 5. You know, coordinating appointments and things looks like most people are solving that problem. Yeah, I think we hear you loud and clear on all of these things. And hopefully, you know, education can help with some of them. But thanks again for everybody coming. Thanks to James for joining me, and we'll do this again sometime. Have a good night.
Thanks. This was fun.
Thank you.
Thank you.